Hey Zach, how you doing?
Hey buddy, how you been?
Good, how are you?
Good, good, good. You're presenting today?
And
Henry?
you had your kid already, right?
Yeah, 1 month old.
There you go. Congratulations.
Thanks, buddy.
Boy or
Yeah,
girl?
boy. So we got one of each now.
Oh, that's awesome.
Yeah, no, it's been fun. I was off for most of August, so
Okay. All
getting
right.
back in the swing of things.
Sleeping or not sleeping?
You know, moderately, but not gonna complain.
Yeah.
How you been?
Good. Good. How's the job otherwise going?
Yeah, plugging along. I think like everyone else, volumes are up and
Yeah.
not the typical summer, but
Yeah, definitely. It's
Yeah.
been really weird in terms of pathology.
yeah. How many fellows do you guys have a year? Is it
Two.
two?
Yeah.
Do you know I was gonna like send out some emails to people in the area. Do you know if either of them have any career thoughts? Are they both going straight into jobs, do you think? Or
I think they both want to do straight into jobs, I think. But they're unsure being that with the new, before we had no jobs, but then now there's jobs everywhere.
Yeah.
But I think they're both limited to they want to stay in the area. So I think that's gonna be sort of the big driver for them.
Is that the general consensus? Is that jobs are opening back up?
Yep.
Yeah.
Yeah. Are you the brown listserv? I mean, yeah, I haven't seen a lot of job openings.
Yeah. I mean, I don't know what to make of that because it's always in like, you know, other areas. So
Yeah.
it's like, you know what I mean? So it's kind of like, but yeah, I sort of get that impression too, which is, I mean, it's good. Last year was kind of nuts.
Yeah.
Yeah. So,
Hey folks,
Hey, Julie, how you doing?
good, how are you?
Good. It's nice seeing everyone back. So
How was your birthday month?
it was great. It was good. Because it's my daughter's birthday as well. So she's turned 5 last week. So
Oh, happy birthday.
yeah, so she shares my month. So she always goes, your birthday's first, mine's next. So she had a bigger party, so that's what matters. So
where's matters more at this point?
Zach, how far along is your wife? Or she already have the baby?
Yeah. Turned 1 month yesterday.
Oh my gosh, congrats.
Thank you. Yeah, everyone's doing good. I'm like reemerging into society. So
Yep.
I was like, this will be nice, catch up with folks. But yeah, you been good?
Hey.
Have you been good, Julie? Yeah.
Oh yeah, thanks. Yeah.
Yeah.
Nothing's really new.
I was actually going to text Adam and see how he was doing in New Jersey, see if he got affected by the
Oh, yeah, that's a
storm.
good point. That's a good
Yeah,
point.
because
Oh yeah, did you guys get storm over there? You guys
I
get
just got a
hit?
lot of water. So
Yeah, it's kind of like a normal rainstorm for us. So I don't know.
Yeah, we had a lot of winds and like flood flood warnings. Those like like a lot of our neighbors have like water in their basement and stuff. Our power went out for like maybe a couple of hours, but we were nervous because we just did a whole bunch of landscaping and like just planted the seed, and so I think we may have to reseed some things, but I feel like those are first world problems, so I know.
yeah.
Julie, I did the exact same thing. I was like bemoaning it this morning. Like everything.
Oh, you did. You're landscaping your house too.
I planted a little grass and then I went out this morning and it was all like funneled into like one corner. I'm like, oh my gosh.
First world problems.
Yeah, no, yeah.
We fared pretty well.
Amongst all the issues, I'm not complaining.
Yeah.
My daughter's tomato plant died because it was like
Flooded out.
Yes.
Oh.
I don't think it's gonna make it.
Oh. I'm
Yeah,
shocked my tomato plant's still there. We planted it late, so it's still all of them are still green, but it's like it's on our patio and I don't know, it's sort of like roped around the like the fence around the patio, but it stayed there.
That was good.
Yeah.
Oh yeah, I think so we'll see. I don't think it's gonna make it. So it gave us all of 3 tomatoes. So I think that's a win. I'm gonna take it as a win. And then
All right. Yeah. 3 tomatoes,
It's
homegrown.
easier than learning the lesson with like a goldfish too, right? Like
True.
plant versus like living creature, you know?
Hey, Antonio and Rahul.
Let's see.
Antonio, a little
He's
chilly.
wrapped in a blanket. Yeah.
Like the office, there's nobody at the offices. It's just like an ice box in here right now.
Oh.
It's got to be like 55 degrees. So cold.
For me, actually, in this office, because I'm using the fellow's office because my computer is being really slow. It's hot, so I'm like sweating now.
All that computer heat.
Yeah. It's actually Hannah just joined one of my previous fellows. I'm in her office, her previous office where I am right now. So otherwise my computer would not start. So we'll wait till 1:05 and then we'll get started. And Rahul, no blanket for you, Rahul?
No, I left all my vests at home, so you know,
Yeah.
next time.
That's
His
your thing.
his thyroid's working better than mine.
I was gonna say, where's your best? You know, you always said that, you know, keeps you warm, but you get cold.
I maintain it's the most versatile form of outerwear that exists.
You
I need
know,
a vest.
Is anyone actually going to Nashville for that meeting?
I tentatively am.
Are you?
Yeah, are you?
No, I'd love to go to something like that. It just doesn't seem, I don't know.
I know. I know.
I'm very jarred by the fact that the AAP just changed to all virtual.
yeah, I was gonna say
I
that.
felt
Yeah.
like it was like a glimmer of hope, like, okay, they can do, even though I had bought the only virtual option, you know,
I
I
didn't
was
realize
like,
that they came out with that in the last week or so.
oh, it was
Just
yesterday.
Oh, I didn't realize.
Yeah, I was
It-
preparing my
it's-
fellows for the Sono games, and then they texted me today saying it's canceled. So
It really stinks.
Depressing, man. Can you, Julie, can you buy in for like a day only? Did you look that far into it or?
Oh, I don't know. I think the virtual is just all access because it's like
They'll let you into some stuff or
you could access it at any time, you know, the
yeah, yeah.
virtual stuff. So whether you're going for it, it's still like pretty expensive for just like online stuff, but I guess to put it together.
oh,
Yeah.
So let me share my screen. Everyone can see that?
Yes, sir.
Awesome. All right, so welcome everybody. We had a month break, so hope everyone had enjoyed some vacation. I certainly did. I am now 40 years old, so they told me it's downhill from here, or you know. But anyways, thank you for coming back and sort of for the attending. I'll be presenting some cases today, and the first half is going to be sort of a theme, and just want to keep in mind of where we're located. So we're in the Northeast in Connecticut. So just bear that in mind for the first few cases that I'm going to present. And thank you, Hannah, for the birthday wish. All right. So the first case is an 11-year-old with a recent diagnosis of Lyme disease that presented to RD with blurry vision and neck pain. That was lasting for about 3 days. Her Lyme presentation when she was diagnosed was a fever, headaches, and neck pain for 2 weeks. She had no rash, no history of tick exposures, and her Lyme screening was positive, and she was started on doxy. So this was prior to the presentation. So symptoms improved, but 10 days prior to the RED visit, the symptoms started to come back, and the blurry vision started coming, starting 3 days prior to the ED visit. And she's been on doxycycline now for 21 days, as per the diagnosis by the pediatrician, who sent for the Lyme screened and then started her on doxy. Her physical exam, so overall, she's in no apparent distress. She has pupils were equal, round, and reactive. Extraocular muscles are intact. Her visual acuity is there. The left side was 20 out of 40. The right was 20 out of 30. And her neuro exam was completely intact. Normal reflexes, normal tone. And there was no rashes, no target or anything like that on the exam. So this is her ocular ultrasound that was performed. So you'll see right and left. And hopefully I'm not choppy because I'm in the hospital internet. So hoping you guys should be there. So what you guys appreciated from that is obviously the papilledema. So I think in her case, it was around like 1.2 millimeters in terms of the elevation. And the optic nerve sheath diameter was just right around 6 millimeters. And basically, this is a really good shot that I like to show the fellows because it shows you where the optic nerve actually is and the optic nerve sheath diameter, it is. So the two hypergluon lines that are parallel, actually the optic nerve and the optic sheath diameter is sort of like outside of that. So in this case, you can clearly see the elevation indicating papilledema and also the optic nerve sheath diameter as well. So the ED course, immediately we got a head CT that was normal. The LP was unable to be completed in the emergency department because they were attended 3 times and they did not use ultrasound at the time. So basically, patient was, doxycycline was discontinued and the Diamox was started right at that time. Inpatient, the MRI head was normal. They did a fluoro-guided LP with an operating pressure of 57 centimeters, sorry. And the CSF analysis was negative for meningitis. So actually, the diagnosis that ended up saying was that it's idiopathic intracranial hypertension secondary to the tetracycline use for this patient, which I thought was interesting. So, so they cured the Lyme, but then created another problem with that. So let me just check the chat before I move on to the other case. All right. And yep. So yeah. So actually, Julie, just keep that in mind. So as I go on to my next case. So any questions with that case number 1 before I move on to case number 2?
Henry, did you get any sense of like how common a complication that is? I mean, is it like?
So I'll sort of go back to that in a little bit, but that's a good question. That's why I was gonna go back, but yeah, definitely a good question to ask. And then things get a little weird in the next one. So, so the outpatient follow-up for this patient before I move on. So 2 weeks post-admission, she was still on Diamox and she was actually still seeing papilledema, but it was actually improving. But all these are recent cases in the last 2 months that are all actively still being followed by ophthalmology. So I just want you guys to all keep that in mind because one of the questions I'm going to have after I present a couple of cases is, how long, these patients continue to have papilledema for. So case number 2, so is a 13-year-old with history of Hashimoto's thyroiditis and a recent diagnosis of Lyme meningitis brought in by the parents for evaluation of vomiting and headache. So her Lyme presentation was actually pretty interesting. So when she was initially presenting with symptoms, she complained of headache and neck pain for approximately 1 month. And there was a possible rash, and the only reason that it says possible is because once she was diagnosed, they started looking at pictures of skin findings they found, and so maybe they saw a target lesion on the right ankle that they didn't bring up to anyone, and sort of no one looked for it because apparently it was tiny. But this is sort of like going back once they were, diagnosed. She was seen by urgent care where actually Lyme screen was negative when she initially presented. She came to our emergency department, and then basically she had just improved with just some Tylenol and was sent home. And then after that, she was lucky enough to go to Hawaii, where interestingly enough, she was stung by a jellyfish. And per report by the parents and the patient, after that, she developed like a target rash appearing everywhere in her body, which after basically that was just happened right after, right as they were leaving Hawaii. So they came here, went to the pediatrician, and also saw persistent headaches along with that, all that rash, and triggered them to come to the RED and be admitted at that time. So during her admission, so this is before she actually presented again. So her histology was normal. CSF was, an LP was done, but they weren't able to get an opening pressure. But her CSF analysis was consistent with meningitis. So CSF, they would show 49 white blood cells, protein was 27 and glucose 49. And interestingly, this is one of the reasons why I think I wanted to bring it up. Ophtho was consulted because in either the first visit and sort of the urgent care and the pediatrician, and even on admission, there was no documented ocular exam, which I found just to be sort of a little worrisome. The fact that no one, I don't know if it's, it was they tried and they couldn't see anything and they didn't document it, because the patient was a little difficult. She didn't keep her eyes there. I find it interesting that Ophtho was consulted, and they're the ones who diagnosed papilledema while she was inpatient. And she was diagnosed with presumed Lyme meningitis that they thought was causing the pseudotumor or idiopathic intracranial hypertension. She was started on ceftriaxone and Diamox, and she was discharged just because, as probably in the rest of the, we're seeing an increased volume. Our hospital was full and they were trying to get patients out. So she got a little better, but the Lyme screen was pending, and they started switched her over to Doxy and started her on Diamox and sort of send her home with those. And then just, it goes back to sort of like, I remember Aaron Chen gave us a talk last year about ocular ultrasound, and based on one of the studies he was involved in, only 40% of the time they documented sort of an ocular exam, which I think it just brings an importance of actually being able to perform an ocular ultrasound, especially at the bedside, because I feel it adds, in this patient, it could add a lot more. And sort of like not being able to need Ophtho to come in and sort of diagnose that. So she returned to our emergency department 3 days post-discharge from her admission. And her chief complaint was headache and vomiting. And she was currently taking doxycycline and Diamox as what she was discharged for us. And her Lyme screen actually came back and was negative. And there was no concurrent visual changes or sensitivity to lights and sounds, and no fevers. On physical exam, she was in no apparent distress. Pupils were equal round reactive. Extraocular muscles were intact. Visual acuity, as you see there on the left side, it was 20/15, and then on the right was 20/20. Neuro exam was completely normal as well. And sort of this was her ultrasounds. So right and left, as you guys see it. So this one, I found that it wasn't as obvious as the first one. I remember doing this, I believe, with the resident, and it was initially sort of almost skipped over because the patient was not as cooperative and sort of moving around. But I think on the left side, you can clearly see that there is some elevation there. So it was about 1 millimeter on both sides that we saw the papilledema. We measured the sheep diameter, and it was right around 6 or right below 6 millimeters on both sides. So in the ED, so we checked some labs, so CBC and lights were normal, but the patient improved after just IV fluids, and neurology was consulted because they were initially consulted during admission. And the recommendation was just to increase the Diamox and just send her home at the end that she got better with just IV fluids. So an LP was deferred just because they didn't feel like she was as symptomatic as when she initially presented. And outpatient follow-up, so she was follow-up recently, that's about a month out, and they still saw some improvement in papilledema. But in this case, I'm questioning the Lyme meningitis. I know infectious disease was involved, and they really thought it was consistent with Lyme meningitis based on the history, just with the target lesions, the bullseye rash that they saw, and sort of like this whole history. And they called it Lyme meningitis, but they were all waiting for the Lyme screening, which came back ultimately negative. So I think this probably was maybe viral meningitis causing sort of like this against pseudotumor again. So any questions with that one? And let me just catch up on the chat. And then they did a whole, just to answer the questions from Lei, they did a whole viral panel from the CSF, and everything was normal, including enterovirus as well. All right, I'll be moving to case number 3. So this is a 19-year-old history of anemia who presented to our ED department with 1 month of progressive headache and blurry vision. She actually was evaluated outside hospital. It was an adult hospital 2 times prior to coming to our department, where they did a head CT that was found to be negative. She was ultimately diagnosed with migraines, and in one case, she actually was given morphine the second time in order to send her home. The blurry vision from the left eye and left leg weakness started to begin, and that's what concerned her. And she actually started developing some proptosis of the left eye a couple of days before coming. That's what really triggered her to come to our ED department. And no fevers. Again, there was no really a good history of whether they did a good ocular exam at any point. So just again, so this is her actual picture. So this is exactly when I walked in the room, and this is what I saw with the fellow. So obviously you guys can see that she has left sided proptosis, and the extraocular muscles are abnormal just on the left side. The rest of the neuro exam, there was normal reflexes, but we did notice weakness in the right upper extremity, just very mild. Reflexes were normal though. But I thought that was pretty impressive there. So it was very helpful to have ultrasound handy, as you can imagine, it would have been really hard to perform an ophthalmological exam on this patient. And then these are the images from her as well. So I think you guys can see that there is pretty obvious papilledema bilaterally. And if you were to measure the sheath diameter, it would have been elevated as well. But it was equal bilaterally on both sides in terms of the amount of papilledema that I saw. So we were lucky enough to get an MRI at that time, just because we got lucky that there was some space, and she's 19, so she didn't need any sedation. So we were able to get a quick MRI where there was bilateral proptosis, which I found, never kind of seen this. There's actually a measurement they did on the MRI itself, and they noted that the proptosis was bilateral and equal. And it was a little unusual, being that on exam, you can clearly see that there was left-sided proptosis versus the right. But when they went on the MRI, they thought it was even on both sides, and obviously they saw papilledema as well. No masses. this patient unfortunately refused an LP and the ED for, even though I was adamant saying that it will, improve her her symptoms because she was still with a headache, but she was just scared of when we mentioned that there might be some nerve damage. She just clung onto that and basically said, no way. So we called neurology and started the patient on Diamox, and she was consequently admitted. And before I move on, let me just check. It's true. There was an outbreak. So she actually let them do an LP 2 days after the admission. Opening pressure was 27 centimeters at the time, and the CSF was negative for meningitis. However, the Lyme screen was positive this time around. So she was discharged on Doxy and Diamox as well. And then sort of her follow-up visit, that was about a month now after her hospitalization with ophtho. So they saw improvement papilledema with Diamox, but in between they had a visit where she still has symptoms, so they had to increase her Diamox. And then with that increase in Diamox, that's when her papilledema was still, was getting a little better by this time. But this is another patient where it's almost a month out and they're still having papilledema. So yes, Slade, she did have cranial 6 nerve palsy as well. All right. And my next case, last case, is case, but just to keep this theme, is a 5-year-old twin with recent viral meningitis presenting with headache and blurry vision. Her hospitalization, they found a normal CT. Ophtho diagnosed her once again with papilledema because there was no ophthalmological exam performed either on admission or by the ED provider. And I can understand because she was very anxious when I actually met her. So this was one definitely, again, where I think it shows how the utility of the ocular ultrasound that we can perform, because even though she was moving, I was able to capture enough. And then I'm just gonna answer one quick question. So the MRI, it did not show any white matter changes for the previous case. So going back to this case, so opening pressure was 33 centimeters. There was nine white blood cells on the CSF analysis with lymphocyte predominance, low glucose and normal protein. So they felt that was suspicious for meningitis. And obviously the biofire for the CSF analysis was all negative. She was evaluated by ortho on the day of presentation and just saw the papilledema again that was worsening. And that's when they sent her over to us. There was no fevers. And as you can imagine, she was on Diamox where she presented to us. So on exam, she was very anxious. And one of the reasons is that when they performed the LP on her prior, it took like 4 times attempts to get it. So basically that was her main fear, the fact that we were gonna have to do another lumbar puncture on her and it would be as traumatizing as her previous state. An exam, basically, pupils were equivalent react, there was no palsy, neuro was intact, and that's pretty much it. So I managed to quickly do an ocular ultrasound on her, and rewardingly, I was able to see, once again, the papilledema. And one of the things I wish in all these cases that if there was a previous ultrasound performed just to compare and see if I can see a difference, but none of these had a previous one. But once again, you see the cupping again, and this one, I think her chief diameter was over 6 millimeters as well. Luckily, because I was on with a fellow, we did an ultrasound LP and we got it on first shot, which made her very happy, but it was under propofol. Her opening pressure was 53 and the CS analysis was negative for meningitis. And Diamox was continued and she was admitted to the hospital. And then discharged, I think the next day, because after the LP, basically she felt 100 times better. So this patient is actually kind of the worst out of the ones, is that a month out, And I think this was as recent as last week. She followed up with ortho and she was worsening symptoms again. And then so an LP was ordered and it was going to be her third LP. And she was going to be referred to neurosurgery for a possible shunt as well. So this one is sort of the worst. So I wish, Lay. So this triggered me. And the reason why I brought this up and to give a theme is that in the Northeast, I don't know if you guys are aware, the tick population is on the rise in Connecticut. So they count more than double the ticks through April, and that was since compared to last year. And then basically we have 3 new strains, including the Lone Star, the Asian Longhorn, and the Gulf Coast tick. I just found it just pretty interesting because that is the Lone Star tick. Obviously, because you can see, I guess what they looked at as a star, but that's sort of like an invasive species that actually around the area of by the shore, that's where they're increasing. And just to give you a sense, because when I went into the DPH to try to get a sense of maybe the increase in cases of Lyme, they don't have one. The last one they have 2019 is, so it's not as recent, but this gives you sort of flavor as to like the rate of increase is that so far, and this was as of early August, there was 4,700 tick submissions to the laboratory compared to the whole annual average of 3,000 in Connecticut. This is specifically to Connecticut. So something to, that's what I found very interesting. So, so I actually sent some of you guys an email seeing if you guys had any cases, because I was thinking of writing a case series because I just found it to be unique. There's an increase, the increased incidence of pseudotumor in all these patients, 2 associated with Lyme, and then 2 others associated with meningitis. And to answer your question, one of the questions is, it's uncommon to have, especially with the proptosis. I only found 2 case reports where Lyme meningitis ended up causing proptosis on a patient, sort of a similar presentation to ours. And there is no clear explanation as to why that would happen. And then the pseudotumor secondary to tetracycline use is also uncommon as well, but we saw probably 2 cases of that that I just presented. And this has all been in the last, they presented between July and August in our emergency department. So that was kind of the theme. So then I'm just going to read some comments. No silly questions. So I measured the optimum sheath diameter, not for papilledema. I just do the papilledema for the cupping that, I use 1 millimeter as my standard. And then I just want to see if the sheath diameter is increased or not. So, and this goes back to sort of like the comment of when Aaron Chen presented in terms of like, what if you see papilledema cupping, but a normal sheath diameter, what entities are those? And actually that's, no, the one that, sorry, that what I meant to say, if there's no cupping, but you have an increased optimally sheath diameter, there's no real, answer as to what does that mean. There's actually been some papers that I share with him and by neurology, not by PEM doctors, where for neurology, they had a clinic that just sees pseudotumor patients and where they train their techs to do ocular ultrasound for about 6 months and essentially did an ocular ultrasound at all the patients that came in for an LP. And what they found was that in some patients, the sheath diameter increase comes before the cupping. So they sort of like just want to make people aware that if you see that, it might be the beginning of pseudotumor before you see actually the papilledema, which I found very interesting. And I shared that with Aaron Chen, but unfortunately they didn't include any clips or any images so that we can see, because as you know, measuring the sheath diameters can sometimes be a little bit hard and and controversial. So something just to keep in mind for that. So and that's it. I'm just reading the comments. And apparently in the Midwest, we're also seeing an increase. So thank you, Hannah. Questions regarding ocular ultrasound before I move on? from the Lyme meningitis pseudotumor realm. It's good to hear from you, Adam. I was worried that maybe you were affected by the storm. But if you guys have any cases similar to us, if you want to send them my way, I was thinking of writing a case series on it because I just found it to be unique. So if you guys have any cases, please feel free to reach out to me. That'll be great. All right, so I'm going to move on to the next. All right. So case number 5 is a 3-year-old immunized who presented to our emergency department with acute abdominal pain. It woke her up suddenly at night, vomited once, and it actually went back to sleep, and then woke up again a few hours later complaining of right lower quadrant pain. No fevers or diarrhea, no previous episodes as well. On exam, her vital signs, as you can see, they were overall pretty much stable, and her abdomen was soft, but the resident reported a fullness in the left lower side. She just felt like maybe it was a poop ball that she was feeling. So she was thinking maybe it's a constipation causing this pain. Sorry, just reading the comments. But as you know, with us, with ultrasound is always my second tool. So when I went to examine the patient, I brought in the resident and said, let's go take a look with the ultrasound. So this is my, basically I went to the suprapubic area and just started scanning. Essentially, I was looking for ovaries or an ovarian cyst or something like that. So on the left hand of your screen, you see a transverse area where you see the bladder and the top and anterior area. But then you see a little bit of, there's some fluid posterior to that as well. And the sagittal view, which I'm sure was not planned, you also see some free fluid as well in those views as well. So I decided to put my probe right over the area where the fullness was felt, and this is what you start seeing. So just for reference, you guys can see my cursor. I just want to make sure you guys see my cursor.
Yeah, we can see it.
So this is as a reference. So this is a vertebra right here, and this is, you see this anechoic sort of complex mass that I'm seeing here. If you guys want to venture to comment of anything else you guys thinking of, but I just saw there was this very like complex cystic that was, and you can see sort of, you see the left kidney right at the end of the clip right here. And on the right side, you see it, because I was basically just moving my probe along the whole area just to show how big this thing was. So I once again did a transverse view of the bladder, or just a little more superior, and that's when you can see the bladder here, and moving up, you see this other and that little complex area, cystic area as well there. So any thoughts?
How old was this patient?
She was 3 years old. So from this, so, you know, my thought is always, you know, with a mass, but also is near the ovaries. So I always worry about some type of ovarian mass. So this is one of the times where I put in an order for a pelvic ultrasound on a patient, and the techs come in and ask me, why am I ordering a pelvic ultrasound on a 3-year-old? And I go, because this is what I see. And luckily I had my ultrasound as she was coming in, and she said, yep, that's an appropriate use of the pelvic ultrasound. So they took her over to radiology, and they saw a complex posterior area and a solid mass, and they were actually able to visualize that there was no flow to the right ovary as well. So immediately called surgery. And then before I move on, let me just make sure I respond to everyone's in the chatter here. And Lay and Adam are going to be correct in their suspicions. So this is what it took out when they took her immediately to the OR. So complex mass, it was consistent with a teratoma. And it was a mature teratoma. Luckily, they were able to remove it fast enough that they were able to save the right ovary. I mean, the right ovary that was compressed by this mass. So that was sort of like the happy ending for this patient, is that she kept her right ovary. So no teeth were visualized or mentioned in the formal ultrasound or in the biopsy. So no Chicaiza nodules. All right.
I'm surprised that they gave you a hard time about ordering pelvic ultrasounds in this age. We order them very routinely, and it's no questions asked. Is that something that you run into trouble with a lot over there?
No, they're just, I mean, they don't deny it. Just the text just like are just like wondering why you order it, and they just want to make sure that you order the right ultrasound rather than like questioning.
Oh, got it.
They just want to confirm that you're, that you're ordering the right study. So, but then, yeah, they saw my images and they were like, "Yep, we're taking her right now to the." So, since we're spoiled, the ultrasound happened really fast, and that's why I think it. And she got taken to the OR rather quickly, so that's why I think the right ovary was safe, and luckily for her. So I think that was, I think it expedited care. So I always tell the residents and the fellows that, that right ovarian torsion is not as uncommon premenarchal, because a lot of residents, especially ED residents, just think that it's just a postmenarchal problem, but it is a premenarchal problem as well. So you just got to keep your eye out for it. So, all right. Okay, so I have time. So my next case, sort of an interesting, it's kind of scary thing that I encountered. So it's a 60-year-old that had no significant past work history that presented with left shoulder pain to an outside facility. So the story that was given was that he collided with another player while playing baseball. Everyone that was there just said that they collided, ran into each other as he was going from the base. They didn't say it was the elbow or like the feet or anything. They just said they collided. So he presented to the SID with severe left shoulder pain. He had no LC, but per the report, he appeared tired while he was there. So they conducted a CT of the head, which was normal. And they did a left shoulder x-ray as well, because that was his primary complaint, that was normal. And actually, this was sort of like when it was a scary thought for the patient, is he was actually about to be discharged home. And then he wanted to go to the bathroom to just go to pee. And when he went to the bathroom, he had a syncopal episode. And then this is where, like, trying to read their notes, is all of a sudden he then had abdominal pain on palpation. So it's unclear whether they check or whether he had like a benign abdominal exam, when they first examined him, and that changed when he went to the bathroom. But nevertheless, after that syncopal episode in the bathroom, before they were ready to be discharged, now on revelation, he had some belly tenderness. So, and then he was diaphoretic and pale. So then they trigger a CT abdomen and pelvis that show a severe splenic injury. So they called me, and I remember the ED doc was, I can tell that he was nervous and wanted to send the patient to me ASAP. And then unfortunately it was a rainy day. And then I forget the month that we almost every day it rained. So he couldn't fly him out. And he could also just, essentially my team couldn't get to him. And he tried to do lifestyle by ground. They were not able to do that as well. So he decided that ALS crew with one of his best nurses was kind of the way to do it. And then I asked him to please do, because his vital signs started getting worse. He was tachycardic, and his blood pressure was borderline. So I asked him if he can have some blood. So he was really nervous and just wanted to get the patient out of there. So he handed the blood and put him on the ambulance and sent him my way. So patient arrives to my AD now, and he becomes hypotensive. So his blood pressure starts going to the 70s, and then now he's coming in and out of consciousness, and not out consciousness, just it's altered when he first gets to me. So I apologize. This video is not going to play for some reason. Something happened to the clip, but this is the right upper quadrant where you can see the liver here, and you see something that shouldn't be there, which is a tremendous amount of fluid in that area. This is a suprapubic view, and once again, just showing a lot of fluid in the area. So a very subtle positive FAS. And interestingly enough, so this is both views of the left upper quadrant, and you can see the left kidney and the spleen there, and just based on that, you can see that the architecture of the spleen is not well defined there. And then just to answer that question, because I was going to tell you that Lei Chen a little later, he was tested for mono and it was negative, because that's what everyone thought, because it was just a weird history. So his CT showed basically a shattered spleen with active blood, active bleeding. This was the images that we obtained once we uploaded the images. And then so I started a mass transfusion protocol on him. That was one of my busy nights, because this is my second one in like a 3-hour shift that I had. So this is the second time I was activating the mass transfusion protocol. So the labs that we got essentially prior to his transfer, his H&A was 12/35. The one I got in my ED department was 7.3/28, 28.8. And then naturally, I activated this patient as a trauma. So then the trauma team came in, and then he was, this was one of the only times I saw the adult surgeon, because in our shop, once it's because this happened around midnight, the adult trauma team, because Hartford's right next to us, they tend to come first, because the pediatric surgeons are home, so they have like I think it's like a 20-minute window to come here. So usually we see the adult trauma surgeons, unless the pediatric surgeon happens to be doing an operation or something and is there. But the adult trauma team initially came, and this is one of the only times I saw a trauma surgeon sweating, because his blood pressures continued to drop despite being on blood hanging. His systolics went to the 50s, kept going in and out. And he called the pediatric surgeon and just said, "I'm going to take this patient to the OR stat." So they actually ended up taking his spleen completely out, and 5 liters of blood came out of his abdomen. So essentially all the blood and all the fluids that was pushed on him was just pouring out. Luckily, he made it nice and clear after, with resuscitation and everything. So, but it was the first time that both surgeons told me that had taken the spleen directly out in years. So it was definitely a scary case. The parents were like outside themselves, because they initially were going to send home, and all of a sudden we're telling them that their kid is like about to die in the better sense of the word. So yeah, but this was an interesting case. So gave me palpitations because I thought he was dying in front of me. But anyways, so that's case number 6. Questions. There was no mono. Like I said, mono was negative in that one. And then everyone asked the family if maybe he was hit with the elbow or anything. No one could sort of give us a clear history. So it was definitely a weird presentation. Because I remember when I first heard the story, I was like, it's going to be nothing, because he just collided with a patient, with another player. But it turned out to be a very severe injury. So, so I think this is, let me just check the time. This might be my last case, but I want to just check. I have 2 more cases. All right. Yeah, I don't want to give you an MI, Antonio, but yeah, it almost gave me a heart attack while I was there. So because we're in a pandemic, so I'll give you this patient. So this is a 12-year-old who presented with fever for 5 to 6 days, associated general abdominal pain, nausea, vomiting, and diarrhea, was unable to tolerate PO, had increasing pallor and fatigue on the presentation, no cough, congestion, or rashes, and actually developed some eye redness once he arrived to the emergency department per mom, which was confirmed by me because this is one of the times that the nurse kind of dragged me to go see him immediately. So when he first got to our ED, so his vital signs, so he was febrile 38.1, his tachycardic 140, but as you can see, his blood pressure was abnormal, 82/43. Respiratory was 26. He was sleepy but arousable, GCS was 14, but appears sick. Peripheral pulses 1+, but the cap refill was a little delay. So we're in a pandemic, so first thing I always think about is MISC now. So I immediately grab my ultrasound and sort of go and do my cardiac exam. So my cipher view, I see, as you can see, I don't see any fusion there. I went to proceed my IVC just to see if it was flat or overfilled. It looked about in the middle, so it was not a fluid issue. And then this is his parasternal short, looking at the squeeze. And what do you guys think of that squeeze? I like the guesses. So 10%, I got 35%. I got a request to go back to the IVC, so I'll go back. And I specifically like the mess squeeze scripted by Adam. So, all right. So I was at the bedside throughout this whole patient with the son because everyone was worried about him. So we ordered the MIC labs. Ironically, he was also had a scrotal pain and an appendix pain on exam. What was interesting was that, and that's one of the things I wanted to bring up is I immediately called the PICU doctor and the cardiologist because I saw the abnormal squeeze. So I was like, this kid is going to the PICU and I'm going to start pressors. And I knew the PICU was full, so I wanted to give him an early heads up to get up there. But he wanted me to give him IV steroids first because he is he was part of the group that published that Lancet paper on MIC complications and response to treatment. And he said that he's seen some patients respond with just IV steroids before starting them on pressors, which I thought was interesting. And like I said, I trust him because he was part of that big consortium from the Lancet paper that was published. So I gave him a 10 cc per kilo normal saline bolus, just very slight, not to send him over to failure. Obviously, I gave him antibiotics and I ordered an echo. And this was, fortunately, it was like 10 in the morning, so everyone was around. So I was interested if you guys have seen that, with a response, an immediate response with steroids that he's seen. So that's why, like I said, I didn't question him just because I know he's well versed in MIC and all this complications and treatment. So I just wanted to see if you guys have seen that as well. Yes, I think, Adam, I think that's your statement is true. So, and then Late, do you want to sort of talk about your transverse IVC views as to what you're looking for?
No, except to say I think it's just better.
Okay. So in this case, let's see my next slide. So since cards was it's 10 in the morning, everyone's there. They immediately came. they did a bedside echo. His replay blood pressure, even though with the steroids, didn't really respond. I gave a second bolus, but then I sort of started him on dopamine just because he was not getting any better with the IV steroids. But his story got a little interesting. So the nurse called me back because he was moved to our medical resuscitation room, got a little better, but then felt like, interestingly, said that he didn't look well again. So we had a medical student with us that went to reassess the patient. And she was scared to kind of bring it up to our fellow that she heard a gallop. She's like, this is my first time that I'm hearing a gallop. I'm a medical student. So she went to my fellow and said, I think I hear a gallop. So my fellow went in and, concurred with her findings and said, I hear a gallop. So they call me and then I grab my ultrasound machine, as you guys can imagine. I'm not sure why it stopped playing. Let's see if I can go back. So this was the parson was short after the dopamine was started and when the gallop was heard. As you guys can see, I thought I showed a great response to the dopamine. So the squeeze, I think, looked dramatically better, even normal. And cardiology was right next to me as I was, because I called them because she was like rounding on the patient at ED, came in and said, yep, that looks great. And I said, do you mind just listening to him just to make sure that he has a gallop and I'm not, and this is just to show you sort of the difference before I move on. So on your left side of the screen is the one before the dopamine, and on the right side is the way that it was after the dopamine. So you see a dramatic improvement with that. And then, yes, I agree with you, Lei Chen. I felt here at my institution, they like dopamine. Levofed is what seems, I think it's preferred by most institutions, but I've been having a really good answer as to why dopamine, because this was also ran by the cardiologist that was there at the bedside when I ordered dopamine, and they wanted to start with dopamine. So, but I haven't had a clear answer as to why we prefer that here as opposed to Levofed, which is what I've been seeing is sort of the choice agent nowadays. I repeated an IBC just because I was there as well. Looks a little plumpier as well. And I was a little concerned that a little too plumpy, but that was something I saw as well. So, and then I don't have clips, but I also I did a chest to look for B lines to make sure I didn't throw them into failure, and I didn't see that as well. The blood pressure drop, I heard a gallop, our dopamine, sorry, the way this, so the blood pressure initially dropped, that's what brought us in, and then we heard the gallop. The patient was at 10 mics per kilo per minute. So then after we examined him, the blood pressure started coming up again. And cardiology couldn't really tell me a good reason as to why he had a gallop. He was clearly not in failure based on everything we did. So what they decided to do was decrease the dopamine and start milrinone and then admit him. And then by the time he went upstairs, they heard a gallop, but a little after that, the gallop disappeared. But no one could give me a real good answer as to why it started to, it was there to begin with. Eventually, this patient got better with the, they gave him the IVG and everything. But it was very interesting as to, I can't, explain to you pathophysiology speaking as to why he had a gallop. And, when we're able to see the heart pumping really well, I was able to see that there was no B lines. And then, so I wasn't sure why we heard a gallop, and this was confirmed with the cardiologist as well. So it wasn't like I wasn't imagining anything. So it was interesting. So I just want to see if you guys heard of anything, and I'm going to start. I started in the ED, I started pressors, gave the Decadron, and then they gave the IVIG upstairs in the PICU, Adam. All right. No. And any questions with that one? All right, just in time for one more. This is my last case. So this one is a 17-year-old female with 1 day of vaginal bleeding and lower abdominal pain. She had a positive pregnancy test in the at home. Based on her last menstrual period, she was supposed to be 7 weeks pregnant. No fevers or vomiting. On exam, she was overall well appearing. Abdomen was significant for just tenderness palpation in the lower abdomen, and there was blood in the vaginal blood with a closed cervical os. So our fellow, they did some lab work just as this is after the ultrasound, but just it's important to point out. So her ACG was over 43,000. Her H&A was stable. But in the meanwhile, so they did an ultrasound, and this is what they saw. So this is the sagittal view, and I want to see what you guys think you're seeing. Sorry, it's not on repeat, so I have to keep pressing play. Sorry about that. I'll give you another view. So I'll say a couple of comments. Bicornate uterus, gestational sacs not in the middle. I'll give you a couple of other images. We did not measure that, Stephanie's. And I believe this is the transverse, I believe. Yeah, this is transverse view of that. Make sure that's my last slide. So, all right. All right, so another comment is twin pregnancy. Yes, that is, so actually that is what my, the thought process was initially. Luckily it happened during the daytime as well. So obviously they're concerned, you know, the stational sacs there, but there's something posterior to that. You know, the concern was maybe is this a twin pregnancy, that abnormal, you know, so OBGYN was consulted and they actually saw our images with the fellow there, and they actually diagnosed it with subchorionic hemorrhage, which actually turns out to be a common cause of first trimester bleeding. Because the patient was well appearing, H&H was stable, and they were happy with our images. They didn't want a radiology, they didn't want a confirmatory radiology ultrasound, so they actually discharged the patient home, which is close follow-up. And the patient 1 week after developed some pain, and then came back to our AED, and then there was no fellow there. Or someone that felt comfortable. So a radiological ultrasound was performed. It actually confirmed the POCUS findings. H&H was unchanged. GYN was consulted and just said that it was a threatened pregnancy, but it's overall stable. So they were going to just do an outpatient follow-up, and then it hasn't. I haven't seen the sort of like their last note on you know what is going to end up happening with this patient, because it was a very recent patient. But I didn't think I found. I think I found just one case of this on an adult patient, not on a kid. So I recommended my fellow if she was interested to write this one up. But I thought that was very interesting. And yes, when I was reviewing this, I was like, having a little heart attack. I was like, what is that? And what happened to it? So once I read the notes and saw that it was just that, I definitely Googled that and said, what is that? And so one of the things I learned is that most commonly it's confused with a possible twin gestation. So it's something that's commonly missed. So something to definitely keep an eye out with when you're performing ultrasound. So when you see some type of anechoics or suspicious looks like bleeding posterior to the gestational sac, something to consider and keep in mind, as this basically doesn't require acute intervention as long as the patient is stable and with a normal H&H. So, yep, but I think that is it. So I hope you found my cases interesting. So, yep. So again, if you guys have any ocular ultrasounds with papilledema related to meningitis, just let me know so we can add those up. But otherwise, that's pretty much it.
Thanks, Henry.
See you guys.
Say hi.
Hi, Henry.
Bye.
That was Andy saying hi.
Glad to hear you, Andy. I was like, who's that?
Your video is not working. I
Oh,
don't
is
think.
it? Oh.